Um,
Hi.
so I don't know who knows each other. This is a little bit of a different crowd because we're probably like coming up to membership time. So people are either studying hard or most of the people that come have already passed their memberships and they just come for fun, which is weird. But so Helen's sitting in a few weeks, 2 weeks, right?
Yeah.
Yep. So we're going to have this tutorial, and then one more tutorial before most people sit, but I think some people might be sitting that on the day of the next tutorial, which means that we're just going to mess with the structure slightly. So the topic we're supposed to be covering today is obesity, sarcopenia, cachexia. But we're going to try and make it more kind of quiz style. And there's going to be a few pop quizzes on topics outside of that because that's not a very examinable topic. When I was kind of looking through, I was like, there's not many questions here that I can ask. So is everybody, I don't pick on anyone directly except for Helen because I have her consent. But if anybody else wants to have a go of answering, you're very welcome to pipe up. And I might maybe indicate that you should have a crack, even if you don't volunteer. Hi, Bron. So you've already passed as you've already done your memberships as well, haven't you?
Yeah, but it was a long time ago. They definitely need refreshers.
I'm reading these chapters, Bron, in Edinger, and I feel like it's a completely different specialty than it was when I went through. Like
Yeah, I just went to check for my old Ettinger and to see what was in the chapter, and thankfully I don't have it anymore because it's probably all incorrect.
well, it's like there's just so much advancement in every single area. Like the book's just getting longer and longer, and they're just glossing over these like really like key concepts that I'm like, that was like the basis of all my studies.
That's why we come here, Anna. It's not weird. You've got to keep up to date.
Yeah, that then relies on me actually providing up-to-date knowledge.
Where
Anyway,
you do that.
okay, so the first topic I think is an interesting one in terms of like new developments in obesity. And there's a lot obviously in humans on obesity, metabolic syndrome, and the impact it has on neurohormonal function and stuff like that, and other body systems, including brain function and everything, like very interesting area. But none of our studies in veterinary medicine are big enough to demonstrate the same kind of significance. But it's interesting. The chapter kind of does go into it, like, which makes it then not examinable, annoyingly. But the chapter does go into a few kind of like translational sort of how can we draw from human data? So what are the risk factors for obesity in cats? Sorry, please.
Having joint disease or osteoarthritis and being less mobile.
Sorry, risk factors for a patient being obese, like signalement stuff that might make them more likely to be obese.
Well, I just said that because I feel like they'll move less. But yeah, so
Oh, for sure. So what environmental stuff might
being indoors only.
right? Yeah, good.
Yeah,
And then gender? Sex?
males.
Yep. Good. In cats? What about dogs?
Desexed females.
Yeah, exactly. So it's actually the opposite. Male cats more likely to be obese, female dogs. What about owner factors that make a patient more likely to be obese?
Ad lib feeding.
Oh yeah, for sure.
Choice of food, I guess dry food.
It's not a specific
Having it.
split between dry and wet,
Right.
but definitely choice of food is like the people that spend on food tend to have high level of knowledge and awareness around the risk of feeding poor quality food and therefore obesity. So cheap food is associated with
Right.
yeah.
The owners themselves being obese and
Good.
might not recognizing that it's an issue or feeding them cheese and bacon and things.
Delicious thing. Exactly right. What about age of owner?
Oh, interesting. Retired owners, older
Older.
owners.
Yeah, and you can fit like this like right from consulting. You can relate to like people coming in with their, like, they're retired and they're besties and they've like both got snacks in their pockets.
That all the cats that I see in practice are obese, like 95%, but we have a huge retirement population around where I work. So why?
Interesting.
That's
It
interesting.
would be so interesting if we could just mine everybody's data in every vet clinic and do like socioeconomic correlations, like age of population and like all of that. That would be so cool. Good. Okay. So, what drives the feeling of hunger or how much an animal is going to eat when food's just put down in front of them?
So you've got hormonal factors like ghrelin, which is produced when your stomach's empty by endocrine cells in your stomach and pancreas. And that's going to drive hunger centrally by acting in the hypothalamus.
Good. Do you have a way of remembering that ghrelin is a hunger hormone?
Yeah, it's like a hungry gremlin. I think you taught me that.
Oh, I don't, because mine is my stomach is growling.
Ah.
So that's one of the way that we kind of describe these factors that are like pro-appetite or anti-appetite is orexigenic, which is a word that I forget about. But if you think anorexigenic, it's the opposite. So eating or not eating, basically. So ghrelin's a really big orexigenic hormone, as Helen said, produced in the gastrointestinal tract. Where does it then goes to the brain, right? And just stimulates the appetite center. Fellowship level, Mark, where is the hunger center in the brain?
In the hypothalamus, the lateral hypothalamus.
Don't know.
I think.
Julian, did you have another answer?
Oh no, is it the arcuate nucleus in the hypothalamus?
That's the what I saw written, but I don't know where that is. Probably in the hypothalamus. Excellent. So in the CNS, there's actually quite a few different receptors. And so all of the kind of internal CNS neurotransmission is not actually ghrelin. So ghrelin's the like kind of local gastrointestinal hormone that stimulates appetite, but then it causes like changes in this arcuate nucleus and internal neurotransmitters, which neuropeptide Y and a Guti related peptide, which again I would never expect that at a membership level, but just interesting like fun fact. And both of those will increase food seeking behavior. So anything that stimulates those two receptors in the arcuate nucleus, wherever that is, will increase food seeking behavior. And then what about triggers for like anorexigenic factors?
When your stomach is stretched.
Great. Yeah.
Something is released, or is it just neurological?
It's a neural arc. Yeah,
Okay.
so it's actually vaguely mediated.
Right.
Yeah. So essentially food intake stops you from eating as much. And then there's what about other neural factors? And does anyone know what from the digestive tract might increase a sense of satiety or fullness and decrease hunger?
Protein and fat.
Excellent, which stimulates.
Cholecystokinin.
Yay, well done, Helen.
Impacts your, like, also contributes to vagal nerve stimulation.
Yeah.
Society. And insulin.
And insulin, good, excellent. Yeah.
And your adipose tissue, so leptin. And serotonin, which is why you feel happy after eating.
Oh, so good. Is it leptin or adiponectin?
Oh, I don't know. I thought it was leptin that's released, but is that the one that's released? The thing that's released by adipose tissue as it's laying down new adipocytes? Is that not leptin?
I don't know. Again, we are definitely at the point where you know more than me. I suspect we'll find ourselves here several times today. But I've got in my list adiponectin as one of the anorexigenic. In
Okay.
obesity, that all gets a little bit sideways because typically, it just gets turned around. We're going to get to that. Sorry.
Anna, what did you call it? Adipoleptin, like ADI.
Yeah, ADIP.
Yeah. Okay.
O nectin.
Leptin. Okay. Cool.
Yeah.
It's
Okay.
and not an L, Helen.
Beg your pardon?
I think Helen thought it was adipoleptin, but it's
Nectin. N, like nectar, but nectin.
Okay, cool.
Excellent. And then there's one more, which is like not really relevant, except that we sort of sometimes talk about it in terms of managing diabetes, is GLP-1, an incretin. So incretins are these little molecules that are released locally, and I'm probably going to get this wrong, but essentially they come from somewhere on eating, and they're the very, very first kind of responses, even before the pancreas starts secreting insulin in response to food. So incretins actually stimulate insulin secretion, and those incretins on their own will stimulate insulin secretion, which will then reduce appetite as well. But the incretins on their own can directly, centrally reduce appetite. Okay. Helen's covered a little bit of this before, but I'm going to go back and just pose it as a question. What is produced from adipose tissue, which will impact appetite?
You mean the leptin that Helen already mentioned?
Yep. So what effects does that have on do you know what the difference in leptin activity is in obese patients versus healthy weight range patients?
Is it that your body doesn't listen to it, even though you're producing it so much?
Yeah, so they get a little bit resistance to it.
You get resistance to it, yeah.
Yeah, and it actually contributes to, like, causes increase in fat deposition in obese patients relative to normal weight, healthy weight patients. So it actually like exacerbates fat deposition.
Oh, interesting.
So the more fat you've got, the more leptin you've got, the more fat you get.
Okay.
So it's a really hard cycle to break from a leptin perspective. And adiponectin does quite a lot of stuff actually, and it's not very important, I don't think, at a membership level, except that there are changes in levels in obese cats and men, so quite sort of specific. So adiponectin is essentially like a hormone that's produced from fat that increases insulin sensitivity, so it helps manage food and metabolism. It decreases blood glucose levels as a result of increasing the insulin sensitivity. It's anti-inflammatory and it decreases triglycerides and is a vasodilator. So a lot of the kind of anti-metabolic effects. So you think, good, more fat, more anti-metabolic effects to protect against the kind of other deleterious effects of fat. But actually the levels are reduced in obese men and cats, which is quite specific, not dogs. So I don't know if we just don't have studies that are big enough. So we lose those protective effects of adiponectin in obese men and cats. What else is when you get really, really fat, what else does fat produce which would be deleterious metabolic function?
Pro-inflammatory markers.
Yes, good. Exactly. Do you know just fellowship level? What ones?
You can't go wrong with interleukin-6. It's always interleukin.
It's a good point. Excellent. Interleukin-6 is one of them. And there's another one that you can't go wrong with that you should just throw out if you ever get an inflammatory question.
Oh, interferon. No. Tumor necrosis factor.
Yes. Beautiful. Oh, sorry. Yeah, tumor necrosis factor, exactly. So the two that I would like to just have in the back of your mind, IL-6, tumor necrosis factor, both produced by fat cells themselves, but also actually when you get too many cells trying to be serviced by one blood supply or too much tissue being serviced by blood supply, you actually get necrosis. So there's actually sort of cell breakdown, which increases the amount of inflammatory mediators in circulation, as well as just the local kind of fat-produced inflammatory mediators. So how does obesity cause disease? What diseases, let's somebody throw out one disease that obesity contributes to.
Diabetes mellitus.
Good. How does obesity impact dogs with diabetes?
It causes insulin resistance. So even though they have truly insulin deficient diabetes, or mess with the ability to control them well.
Good. Excellent. It's usually pretty uniform, and it typically, like, as in where cats, their insulin resistance level like fluctuates all over the place and they can be really, really hard to control. With dogs, obesity just generally means that they're going to be on a slightly higher dose of insulin consistently, but you can get control of them. And they don't get anywhere near as much insulin resistance as cats do. So let's talk about cats. How does obesity contribute to insulin resistance in cats? What's the mechanism?
I don't know if I really know what the mechanism is.
What happens when you can't access the glucose in your bloodstream? What are you going to use for energy?
So you're going to break down peripheral fat, which is what insulin is amazing at preventing. So they don't have the action of that. So they're going to break down all their peripheral fat reserves and break their triglycerides into free fatty acids and glycerol to use for energy instead.
Yes, great. What does lipemia, how does lipemia cause disease? What?
It increases viscosity of your blood, and so it affects your microvasculature, so it can predispose to things like pancreatitis.
Good.
It can cause lipid thromboemboli, so it can cause little infarcts in tiny capillaries, like in your kidneys, and in your eyes. I don't know the exact mechanism of why that's causing insulin resistance. Does it stop your cell being as receptive to it? Must do. It must affect it at a receptor level or something.
I used to know that. I can't remember right now. Sorry. So pancreas for sure. What does a liver look like in a hyperlipemic dog?
It will have increased fatty infiltrates. You'll get like a vacuolar hepatopathy. You've got adipose tissue instead of nice healthy hepatocytes.
Absolutely. And as soon as you get accumulation of anything in the liver, to the extent that it increases liver size, all of a sudden you're starting to get a little bit crowded in your bile canaliculi, a little bit of intrahepatic cholestasis, a little bit of decreased hepatic cellular function, not to the point of like liver failure or anything, but everything just gets a bit slower and harder when the liver's really busy trying to process fat, but can't focus on the other things that it should be doing. Finally, just had a notification from Zoom asking to confirm my speaking language.
Oh.
Am I particularly mumbly this morning?
No.
Oh, funny. I'm speaking medical. Maybe that's it.
Yeah.
Okay. So cats predominantly impacted by obesity in terms of endocrinopathies. What about orthopedic disease Helen mentioned before? If I said to you, describe or list 4 diseases or processes that obesity will like impact or something like. Do you know what I mean? What I'm trying to say in this question?
Yeah.
So we've got diabetes, and then what else are you going to mention?
Tracheal collapse.
Oh, good. Yeah, airway disease. That wasn't in a textbook. 4 points there. Yeah.
And then joint disease, osteoarthritis, orthopedic conditions.
Huge one. Yeah.
And sorry, I don't mean to take all 4. I was going to say, but anyone jump in if I feel like constipation, old diabetic cats. That
Oh, yeah,
I don't know if it's a risk factor, but I feel
it is. There's 2
just vascular.
Yes, cardiovascular. Good. So that's a really big effect in humans, isn't it? Cardiovascular disease and obesity. Why isn't it as much of an impact on our patients?
cats and dogs don't get a lot of like the arteriosclerosis that humans get and let down in their blood. And it's because they have different ratios of humans can get really lots of high density lipoproteins, whereas cats and dogs get higher accumulations of low density. So humans get more cholesterol issues, which causes more vascular issues. And humans live a lot longer, I guess, and can choose to eat a lot of McDonald's and not exercise.
So you're exactly right. The added kind of fact there is that dogs actually lack, most dogs lack the transferase to mobilize cholesterol from the carriers, like LDL and HDL, at a tissue level. They've only got that in the liver. So they pretty much exclusively process and deposit fats in their liver, where humans can deposit it elsewhere. The exception to that is that they manage to acquire that ability with hypothyroidism. So
Interesting.
And particularly golden retrievers are predisposed to it. And that's like, it's just an interesting fact, but it's one of the reasons why we don't really see that atherosclerosis that predisposes to narrowing of those arteries and fragility of those arteries in the cardiac that's actually deliver blood to the myocardium. So lipemia does predispose to cardiovascular disease when there's comorbidities like hypothyroidism or genetic predisposition to that, but not so much with like we don't get myocardial infarctions even with those patients really. Where it does impact, like what does blood pressure do in an obese patient?
Elevated.
Heart rate?
Elevated.
Yeah, they all go up. Increased oxygen demand. There's more cells. There's more to do, and they've got to work harder to do it. So the same activity will result in the same in those elevations. So if a dog puts on 10% body weight, we see increases in their baseline heart rate, cardiac output, and blood pressure. And interestingly, as people that do echoes, their myocardium hypertrophies.
Oh.
So it's working harder against increased afterload. So it kind of makes sense, like a muscle that's working harder is hypertrophy. But it's actually measurable, and you can see those echo changes over time in patients that gain weight. And it causes, I feel like going into too much detail now, but EA reversal.
Oh,
so the heart has more trouble relaxing. So when it first relaxes and the blood's flowing from the atrium into the ventricle, normally 90% of the blood that goes atrium to ventricle happens in that just passive ventricles relaxing, and it's actually sucking blood in. And it's the late filling is when the atria contracts, so the P wave on your ECG. And that's usually only 10% of the blood that's flowing atria to ventricle. It's the very last bit of blood. Where dogs that are fat, their ventricle doesn't relax as much, and therefore it doesn't suck as much blood from the atrium. So the atrium actually has to do more work to get the blood in. Definitely not membership level, but so interesting for me. So we have to cover it. Okay, pop quiz time. Off topic. Describe the mechanism of action of telmisartan and its impact on blood pressure. Ellen.
Okay. So telmisartan is it's an ARB, so it blocks specifically at your angiotensin 2 receptors. So it's implicated in times when you've got inappropriately excessive RAS activation. So it blocks angiotensin 2, which is primarily function is increased water and sodium resorption through increased sodium in the tubules, and water then follows by stimulating aldosterone release and antidiuretic hormone release. So if you're blocking your angiotensin receptor, you are potentially going to decrease sodium retention and then decrease water that follows it. So you're decreasing preload and decreasing systemic hypertension.
Good. Does it have any direct effect on the blood vessels themselves?
Yeah, it's mildly vasodilatory, and it also reduces. It also has an effect to reduce GFR at a glomerular level. So it reduces GFR by dropping the pressure in the GFR. So that's going to dilate the is it going to dilate the efferent arteriole? Because if you dilate post the glomerulus, you're going to lower pressure. I should remember that off the top of my head. Yes, it's going to dilate the efferent arteriole to reduce intraglomerular pressure, which is why, as well as systemic hypertension, it's got a role in reducing proteinuria.
Yeah. So the one nearly 4 marks there. So you've gone into more depth on the downstream effects, like a reduction in angiotensin 2 decreases aldosterone, therefore decreases sodium fluid retention. But angiotensin 2 is actually a potent vasoconstrictor in the arteriole.
Of course, yeah.
So by inhibiting that, you're actually decreasing vascular tone in the arterial side as well as preload in the venous side by itself.
That makes perfect sense.
Yeah, so two mechanisms to decrease blood pressure.
For some reason, I just always think angiotensin 2, like sodium water, and then everything you read is like vasoconstrictor. I need to remember that and say that first so that I don't forget it.
But this is the trouble, actually, the depth that you've studied to, you've jumped to the more complex part because you're kind of like, oh, that's obvious, but the examiners need the obvious stuff on paper to give you the mark for it. Excellent. Okay. What about the impact of obesity on neoplasia? Do we know what mechanism obesity might predispose to neoplasia in?
I guess any chronic inflammatory condition is going to predispose to neoplasia. And so when you've got fat cells that are releasing IL-6 and tumor necrosis factor alpha and a whole cascade of cytokines, that's going to predispose your cells to neoplastic mutations.
Perfect. And this is where our patients don't live as long, and B, our studies aren't big enough to demonstrate associations, but really the only cancer that's associated with obesity is inflammatory mammary carcinomas. Specific subset of mammary carcinoma, which are just so awful to treat. Like you touch them and the skin just dissolves and they become necrotic and stuff. So very rare though. But interestingly, cancers in obese dogs have increased infiltrates of macrophages. So it's like there's definitely the upregulation of inflammatory response in cancers, which then increases angiogenesis and other kind of downstream effects of increasing inflammation that might be tumorigenic, if that's the word.
Oh, it sounds good.
Thanks. And actually leptin, which is increased in obese patients, increases angiogenesis, is anti-apoptotic. So we kind of rely on apoptosis for cells that have mutated. increases mitosis and also directly increases TNF alpha and IL-6, our favorite inflammatory cytokine.
That's interesting.
Isn't it? Again, not membership level. Don't write that down.
Okay.
Stop making notes. Okay. Pop quiz again. So Helen did send me a list of topics that she wanted us to cover, and because we've kind of already set this tutorial schedule, I'm just now doing pop quizzes on those lists of topics. Describe the effect of aldosterone antagonists. Tell me the name of the most commonly used aldosterone antagonist and its effect on electrolyte movement at the level of the nephron.
Shall I take this one?
Yes.
Spironolactone is the most common aldosterone antagonist that we use. And aldosterone is responsible for, again, maintaining sodium and water, well, part of maintaining sodium and water homeostasis. So increased sodium reabsorption in the, I'm going to say distal convoluted tubule for aldosterone, and then water follows. And so if we block that, we get loss, the sodium stays in the tubule, so we'll get tubular loss of sodium and water, and it's potassium sparing, which is I think what you're getting at, because it doesn't I should know this off the top of my head. Does it affect the pump? So when it's pumping, yeah, so it's a pump. So that pump pumps sodium from the tubule into the tubular cell and then back into the, when aldosterone is working, it pumps sodium from the tubule into the tubular cell, and then it can come back into the kidney, and then water can follow and pumps potassium out. So if you block that pump, you're not going to pull your sodium in. And therefore it acts as a diuretic because water is going to follow sodium out of the tubule in urine, but you're going to be able to retain some of your potassium, unlike other diuretics that just let that go as well.
Yes, well done. Excellent. Okay. Do you want another pop quiz, or should we go on with our tutorial?
I don't mind. Does anyone else want a pop quiz question?
Or
team effort pop quiz?
We're all learning from you getting grilled, Helen.
Exactly. Okay. It's kind of on topic.
Okay.
Outline the pathophysiology of insulin resistance. Insulin resistance in cats with diabetes.
Okay. Do we need to know what is happening at a cellular level to cause insulin resistance?
No.
Okay, good, because I don't know that. So the pathophysiology, cats typically don't have complete loss of beta cell function, so they still have some functioning islets in their pancreas, so can produce endogenous insulin. The reason most of them become diabetic is that they have something that's causing extreme insulin resistance occurring, and they might not have normal levels of insulin. They might have had chronic pancreatitis or something that's happened that they do have reduced function, but it's enough for them to live their lives. Then comes along an event that contributes to, oh wait, sorry, did you say just specifically for obesity?
No, just said insulin. Yeah.
Insulin resistance in general. So
pathophysiology of insulin resistance in diabetes.
So insulin resistance then means they could be living their normal lives with a level of insulin that is appropriate, and then you get an additional event that releases another hormone. So you've got hormones that contribute to insulin resistance, like adrenaline. So if they were had a big like prolonged catecholmine, so not just little surges. But do cats get phayos?
I don't know.
Oh, don't know if they had a phayo. Don't know if they.
Would they tell you if they did?
High levels, so your counter-regulatory hormones, adrenaline, cortisol, so if they had sustained hypercortisolemia, growth hormones, so if they got hypersomatotropism, contributes to insulin resistance, and all of those would, and obesity, because it releases a pro-inflammatory state. Can then cause your cells to be insensitive to insulin. So the level of insulin that they were living their day-to-day life with is no longer effective. You could also have things like acute pancreatitis, which could be altering additionally the endogenous amount of insulin that they're able to produce, and contribute to cortisol and stress and pain. Oh, pain, yeah, that's a good, and inflammation, yeah. So sorry, that's a terribly formulated answer, but
I would never, just for the record, I would never ask this in an oral setting. Like, this is a question you need to structure and sit down and like organize the answer to. So you did very well given the setting. And you got all of the things on my list. Tell me what factors might contribute to a reduction in endogenous insulin levels in cats with diabetes?
Pancreatitis.
Good.
Acute or chronic. Because in the acute setting, you could just have inflamed beta cells, and in the chronic setting, you could have them be replaced with scar tissue and fibrosis and no longer function of their endocrine capacity.
Yeah.
What else was going to? Their general health status, so that's probably going to contribute more to insulin resistance than production.
Most commonly, yeah. So there's one kind of like interesting kind of way that diabetes kind of almost perpetuates itself in cats. So they get insulin resistance, then they get
so being hyperglycemic for prolonged periods of time is toxic to beta cells.
Yes.
And I don't know what it is, but I did read recently that because they're then having to produce more insulin because they're hyperglycemic, they also co-excrete something with insulin that's toxic to beta cells. So it's a self-perpetuating cycle.
It is.
I can't remember what it was.
Amyloid.
I thought that was so weird.
Amyloid.
Oh, okay. So then you could have increased. That's so interesting.
No,
okay. Yeah. So then you could. So the longer that cats are left diabetic,
yeah,
potentially the situation is then worse for recovering beta cell function because of the sustained hypoglycemia and that co-export of amyloid with insulin.
So we're going to get beta cell toxicity, and also from the hypoglycemia and beta cell exhaustion from overproducing.
Yeah.
Then amyloid, like we've heard about amyloidosis in like Shar-Pays and things like that. It's like a fibrous connective tissue. It replaces functional tissue, decreases flow through the duct and the pancreas. It really alters pancreatic function if it's deposited in the pancreas.
That's a good term I need to remember. Beta cell exhaustion.
Beta cell exhaustion, I love that one.
Yeah, toxicity.
Right, okay. Back to... so I think that was like pretty much all I wanted to cover with obesity. Is there anything else anybody wants to talk about? We don't really see, like, the metabolic syndrome is like something that's talked about, but we don't really see it in dogs. Cats kind of get it, but that's kind of what we've talked about, right? All of the like downstream changes that obesity contributes to.
Hey, Anna, it mentioned, I think in the textbook it talks about fluted in cats. Is that an actual pathophysiological association, or is it just a chance that like circumstantially they are?
Same environmental factors contribute to obesity and fluted. So it's a combination of both, and they don't really know. Like but they think that increased tissue around the penis can cause like obstruction and more like alterations to flow, and also obesity decreases toileting activity because they don't move as much. So they might hold on more, they might drink a little bit less, and also the dry food cats drink less, don't go to the toilet as much. So there's just an accumulation of like crystalline material in there, and any inflammatory mediators kind of sit around in the bladder mucosa. There was something interesting in obesity and lower urinary tract disease. Oh, more likely to be infected if they're obese, because you know how fluted is typically sterile. If they're obese, much more likely to have an active infection as a contributing factor to the episode, which like may be severe. And increasing age increases risk of infection as well, because typically we used to say, oh, it's like less than 5% have an infection, but it's still worth culturing if they're obese or older. And much more prone to calcium oxalate. So there might be urolithiasis involved in the obstruction if they're obese. I should have quizzed you. Sorry, I just took that question.
Sorry, did the obesity with the UTI, is that secondary or a primary cause of the urinary signs? Do we know?
I don't know. Like if you sample all animals' urine, you'll come back with a positive urine culture in like a lot of them, even when they're not symptomatic. So if we sort of say, well, I don't know what the percentage is that have like bacteria just having ascended into their urinary tract and not actually causing any symptoms. So if we're sampling these cats with urinary tract inflammation and they just happen to have a non-clinical infection, or whether it's the infection causing,
you're picking it up. So potentially normal obese cats may have more sterile bacteria, subclinical bacteria.
But in the presence of active pyuria, which we often have with fluted, it's impossible to see if it's a significant infection. You kind of have to treat it, I think. Along with everything else that you're doing for the urinary tract at that time. Female cats with fluted much more likely to have infections for anatomic reasons as well. I should have mentioned that. Okay, so did anybody find anything interesting in the chapters on cachexia or sarcopenia? I didn't.
As in, was everything boring to you, Anna?
There was no light bulb moments. I think it's just something that like we can't ask any questions on it really in a kind of exam setting. The mechanisms are actually interestingly similar. Like obesity causes increased inflammation, which causes cachexia. And I guess okay, here's a question. Describe the difference between cachexia and okay, describe the difference between cachexia and sarcopenia.
Cachexia is related to disease, and sarcopenia is usually related to age.
Correct. Excellent. That's all. I'm just now trying to think of what else to say. 100%. Okay, what diseases do we see cachexia in? What's the most common?
Cancer.
No, not most common. Actually.
Kidney.
Not most common.
No.
It's a little bit surprising. Yeah.
Cardiac. I'm just going to guess every system until we get there.
Yeah, cardiac. So dogs with stage B2 and C are all cachectic. Essentially, stage late B2, I should say. Stage C or cachectic, late B2. Getting there. So 48 to 69% of dogs with all heart disease have cachexia. Which is kind of more than I would have thought, but they're often also old, and I guess we expect a degree of sarcopenia in those patients. But when you actually plot them over time, muscle condition score over time, they're definitely more rapidly progressive than you would expect with age. So that was one interesting thing. What is the mechanism of, or what are some of the mechanisms of cachexia?
So like we were talking about with obesity, with cardiac cachexia, for example, you're going to get neurohormonal activation from chronic hypoxia. So you're going to get RAS activation, which is a pro-inflammatory state to be in because all of the products of RAS are pro-inflammatory. So you're going to get IL-6, IL-1, tumor necrosis factor. We're just going to list for everything. And
they're the three, literally write them down for everything.
And they contribute to cachexia because they promote your body being in a proteolytic state, which has the adaptatory advantage that when you're in an inflammatory state, your body can break down your protein for amino acids to use for functional things. Like if you're fighting an overwhelming infection, then your body needs antibodies and proteins for the complement cascade, etc. But that becomes maladaptive when you're in a chronic inflammatory state and you're still breaking down muscles to liberate those amino acids, but now it's detrimental because you're just churning through your muscle mass.
Amazing answer. That was excellent. Can an obese patient be cachectic?
Yes, because those pathways are preferentially going to churn through your lean muscle and not necessarily, and you still could have decent adipose tissue reserves.
So we've got loss of the muscle that we have. What about our production protein?
That's also going to be decreased.
And then what is another thing that people often report? Old dog, comorbidities, lots of medications.
Poor appetites.
Yeah, exactly.
So we have reduced intake.
Yeah, decreased protein production. Like if they did eat the same amount of protein or amino acids, they wouldn't generate the same amount of muscles as a result of it. So all of what you described is exactly right, but the link between the cachexic state or the catabolic state is the glucocorticoids, like the stress. So if you think about a dog on pred can't build muscle, they are storing up all the energy for like rapid mobilization and utilization in their liver. And we see a very similar pattern in those dogs with the kind of pendulous tummies and like they look like Cushingwood dogs, but they're actually cardiac dogs. Beautiful. So there was another interesting thing in here. What does our understanding of the hunger pathway and system, how can our like developing understanding of that help therapeutically? Are there any emerging therapeutics which might target elements of those systems?
Do you mean a therapeutic, like an appetite stimulant?
Yeah, good.
I don't know what else.
I don't think it's available in Australia.
Oh, is this the thing they have in America that's like it begins with E, Illyra or something?
Oh yes, yes. That's the cat version.
I don't know what that is. I'm sorry.
No,
I know they have something because I know they have something licensed for cachexia in animals. Yeah.
Ghrelin analog.
Oh, cool.
Yeah. So now you understand exactly why they target that, because that's then going to stimulate the orexigenic neurotransmitters in the hunger center and increase appetite. With very few side effects, like really interesting pathway. So registered for use. There's 2 different products for dogs and cats in America, but it's coming. And then what other given the etiopathogenesis of that anorexia or of that cachectic process, what supplement might we be able to use to decrease its progression?
I would be wanting to increase protein in the diet, high quality protein. I don't know if that's about.
Yeah, absolutely. Yeah, for sure. And then there's actually, a supplement specifically that targets that inflammatory pathway.
omega-3s.
Yeah, exactly. Yeah, it's interesting. Like quite profound impacts on TNF alpha, interleukin 1 and 6 levels in the body. We know that cardiac disease in particular, but all like cancer, renal disease, are also very inflammatory processes. There's maybe don't give omega-3s without consulting with an oncologist because apparently it decreases the efficacy of chemo or something. Because they're antioxidants and you're relying on oxidant damage for the chemo effect. But yeah, definitely for cardiac disease. There's one called coenzyme Q10, which isn't an omega-3, but a potent anti-inflammatory antioxidant, which has quite actually interesting evidence for benefits in heart disease. The other causes of cachexia, we mentioned most of them: cancer, renal disease. Lower percentages of animals are affected by cachexia with those, but it's still a really, particularly with renal disease, I think it's like, you know, there's bony journey cats who are like late stage renal disease. I think it affects much more common, more than the textbook said. But yeah, I guess it's no different mechanism really from what we've talked about.
I feel like studying this made me feel like I'm probably not being proactive enough for my patients. I don't know if anyone else feels like that. I think I probably do put things down to sarcopenia, especially by the time you've got, you know, like a bit of an older patient, and it makes me think I really should. I don't do anything to muscle score patients. You know, we do the body condition score and we kind of weigh them every time they come in. That's great, but it made me feel like I should have a plan of doing something a bit more proactive to intervene with them. I don't know if you have any tips on that.
Every time I read a chapter, I'm like, I'm going to do more of that. And then when I'm actually looking down the barrel of prescribing 8 medications or 8 interventions at once and going, this is so much to comprehend for this client, patient, so much change at once that I'm not going to know which of these changes that I'm making are like the reason the cat stopped eating because I decided to feed it a high protein diet or whatever. Or is it that there's a medication side effect or all of those things? Like I actually think it's really hard to manage these chronic diseases in most styles of practice with most client logistics. Ideal world, we would for sure. But maybe we put like a little like notice on the bottom of our discharge statement. These are additional things. If you want to do absolutely everything, these are additional things you could institute slowly, one change every 2 weeks or something like that.
Yeah, that's true.
Yeah, I don't think we can expect people to come back in every 2 weeks for us to go, okay, now let's try something new.
No.
Some people. I need to talk to you about JJ.
I know. Don't tell me if he's died.
No, he thinks he's fine, but his abdomen's 50.
Oh.
And he's got to say.
Okay.
Anyway. Okay, pop quiz, last one. Describe ECG findings typical of ventricular tachycardia. That's you, Helen. Sorry.
Does anyone want that? So in ventricular tachycardia, you'll have a wide and bizarre, well, you have tachycardia. So depending on the patient, you could have a big dog that's heart rate's like over 240, or even over 200, and you'll is it going to look different between ventricular tachycardia and no, you're just going to have wide and bizarre QRSs, and it's going to be so tachycardic you're probably not going to see your P waves. So you're just going to have really tachycardic and QRSs that are bigger and wider than you would normally expect. So abnormal morphology of them.
Describe the difference between accelerated idioventricular rhythm and ventricular tachycardia on ECG.
I don't know that I can. Why do patients get, I've definitely learned this. Why do patients get no, I don't know if I can. Oh, I've studied that.
Clinically, you've just done a GDV surgery in a dog and you've got the ECG on it.
Yeah.
When do you intervene with the ventricular arrhythmia that they're showing? When would you be worried about an arrhythmia, and when would you go, yeah, let's just sit on it?
One, if it's clinically affecting the patient, so not a patient under anesthesia, but if you've got a patient that's conscious that it's impacting, you can tell it's impacting cardiac output, so you're getting pulse deficits or hypotension.
Hypotension,
or if you're
under GA or not, yeah.
Or if you're having, oh, that's a good point, yeah. If you're having a conscious patient that's collapsing or having syncopal events, or if you're having really sustained prolonged periods of that with marked VPCs throughout it.
Yeah, so there's a rate, there's a cutoff that they say treat, don't treat.
180.
I think so. I was going to say 160.
Oh, 160.
No,
160 sounds good.
Google.
Be more cautious.
Yeah. But essentially, we know if a particularly large breed dogs, because they're the ones that get GDV splenectomies and things like that, typically that we're ventricular arrhythmias in. If we've got a heart rate over 160, their diastolic function is going to be rubbish. Like if the heart's just beating too fast to fill properly, and if the heart can't fill properly, it's just pumping these tiny little volumes out, even if those ventricular contractions are effective. So they usually say, even if the blood pressure is like kind of technically normal, it's going to be impacting the patient if it's over.
Yeah.
I usually go 160, but I also usually just go, something is somebody else's problem. How would you treat it?
Intravenous lidocaine infusion.
Beautiful. Excellent. Are there any oral options for follow-up care if the arrhythmia continues, or in a patient that has not surgery or inflammation associated ventricular arrhythmia?
Yes, you could use another antiarrhythmic drug in another class. So for ventricular arrhythmias, you could use amiodarone, although it's associated with some side effects. And that's a class, I think that has lots of different effects. Like I think that affects the class 3, I think, but it affects works in multiple ways, which is why it's effective against a lot of different arrhythmias.
Yeah. What about in the same, what class has it became?
B1, 1B.
What does that mean?
Is it? Oh, I don't know. You're really challenging me. I've studied this as well and I can't remember it. It's class 1.
Yes, good.
Which is sodium blocker.
Yes.
Sodium channel blocker. Oh, I need to remember a way to just regurgitate this.
You've got it. So
they go sodium, beta, calcium, potassium. Is that the order?
Yeah, good.
The classes, and then miscellaneous.
Yes, excellent. What's sotalol? Sorry, I'm really pushing you.
Beta, so class 2, but it also has other effects. So it's class 2, so it affects beta, but it also affects I can't remember. It falls into one of the other classes as well. Does anyone know? Is that right?
Yeah, it's also class 4.
Oh, okay, class 4.
Potassium. So it prolongs repolarization, so it slows down.
Okay.
The heart just can't contract again because it can't generate a action potential.
Yeah.
Because it slows down repolarization. So beta blockade, so decreases like sympathetic tone and rate.
Yeah.
And then decreases potassium.
Yeah. Okay.
Well done. Pop quiz finished.
Yay. That was fun.
I can't remember what the next tutorial is, but it's going to be very question-based and very pop quizzy. And if you want any specific subjects covered, let me know. And I'll ask my friend ChatGPT to generate some questions.
Hey, Anna, I had a quick question about obesity and cachexia. Have you
Yeah.
ever done any fecal transplants for them? For
Oh, I find this is so interesting. Um, So fecal transplantation is associated with like you modulate so many aspects of the body, and they've now got a lot of studies to show that if you transplant feces from an obese donor to a skinny recipient, they will over time become obese despite no change in their caloric intake or activity levels. It's so interesting. I've never done it, but I'm very interested in some therapeutic skinny person feces. We joke about this because my husband's like 6'5" and like cannot maintain his weight. Like he's really, really lean. And his whole family are like, you need to like just become a donor. You're a perfect donor. His mum's a dietitian. Anyway, haven't done it. Very interested in it. But I'm not sure we screen our donors with enough, or we understand what fecal profiles are causing that change, and therefore actually donor selection with animals when it's actually the human factor of how much they're feeding the dog predominantly, which impacts their weight, like how translatable that is, but very interested. All right, better go.
Thanks.
Guys,
Bye.
see you soon.
Thanks, guys.
Bye.
Thank you.
Bye.
Yeah.